So for postoperative care, some of this is fairly straightforward, so I'll go through pretty quickly in the interest of time. Same-day surgery is certainly safe in most patients, although up to 20% of patients, especially the elderly, may need to be kept for pain control or monitoring. I certainly let my patients return to normal physical activity immediately, and I don't think there's any evidence to suggest exercise restrictions are needed. Surgeons have a major role in the opioid crisis, and there's good evidence that we can reduce narcotic requirements by using pre- and perioperative adjunctives. I use gabapentin preoperatively. That has been shown to decrease narcotic use postoperatively by almost 40%. I also give all my patients dexamethasone to reduce nausea and vomiting. Intraoperatively, it's really dealer's choice. There's good evidence that intraoperative local can be helpful, but there's no evidence about the different techniques. For example, placing the blocks pre-op, post-op, intra-op, what technique you use. So really, you can choose how to put in your local, but just make sure to put some in. Postoperatively, we prescribe way too much narcotics. There's very good evidence that most patients take 15 or fewer doses. I schedule all my patients on acetaminophen and Aleve, and in fact, I now send patients home with only 10 tabs of oxycodone, and I don't give any refills. Many of my colleagues are actually now prescribing no narcotics at all after laparoscopic cholecystectomy, and I think that's really the way we should all be moving. There is good standardized patient education available on the SAGES website. We actually just approved yesterday the updated patient information, so that should be available within the next month or so. And this is really excellent information to give your patients. Readmission after laparoscopic cholecystectomy is up to 8% of patients, the most common reason being for pain control. But some of the more serious reasons include things like fluid collections or bile duct injuries. Bile duct obstruction can be present with right upper quadrant pain and jaundice. These patients will often have elevated liver function tests, dilated ducts, and most commonly we see this from retained stones, but it can also be a sign of common duct injury. Management of these should really be ERCP, and then depending on the findings of the ERCP, hopefully endoscopic management. Bile duct injury was pretty extensively discussed preoperatively, or in the last section. But again, make sure that these are transferred early. You don't want to make the situation worse by trying to fix it yourself. The best chance of a good repair is the first attempt. Biliary leak is common and most common in acute cholecystitis. These have also been discussed, but again, the most common or the most important factor is drainage and ERCP. I typically would not recommend going in and trying to clip or repair a bile duct leak. You're really better off just draining it and doing an ERCP to stent. Intestinal injury is hopefully uncommon, but can occur. These typically need a reoperation and a repair. So in summary, laparoscopic cholecystectomy is associated with minimal pain, fast recovery, typically done as an outpatient. As a surgeon, our role is to make sure that patients recover quickly and get home without injury. And I'm going to skip ahead since we are running close to the end of the session and move on to the error summary. This is really a module that summarizes a lot of the points that have been made by earlier speakers. I think it's important to note that most errors are not technical errors. Most errors are not the surgeon slipped and accidentally cut the wrong thing. Most errors in the operating room are perceptual errors. There's a great paper by Lawrence Way, Causes and Prevention of Common Bile Duct Injury, that showed that most of these injuries are due to the surgeon misidentifying structures. And so really taking that step to slow down and do that critical pause to make sure that you know that you are looking at what you think you're looking at. Only 3% of injuries are really due to technical mistakes, and only a quarter of injuries are recognized intraoperatively. And it really highlights the importance of perception and visual heuristics. Most common causes of error of the misidentification of the cystic duct really are due to inadequate retraction and exposure. We did a study looking at surgical videos on YouTube a few years ago, and it was really shocking how many poorly performed gallbladders are posted on social media. Retraction. And that lateral retraction to really move the cystic duct away from the common bile duct is critical. Starting that dissection too low below the sulcus is also a common cause of injury. And then, of course, variant anatomy, as was so eloquently described earlier. Interpretation of cholangiography is also important, and there's an interesting study that showed that 80% of cholangiograms that were done when there was a common duct injury were misinterpreted as normal. And that just highlights the fact that you really need to not just do the cholangiogram, but you need to interpret it appropriately. One of the reasons that I do routine cholangiography instead of selective cholangiography is so that I get good at doing the cholangiogram and good at the interpretation of the cholangiogram, so that when I'm in a difficult case, I'm able to really interpret it. You need to see both the right and the left ducts. The cystic duct, need to make sure that there are no occlusions and no stones. So in summary, our mission with this whole program is to enhance our culture of safety for cholecystectomy and minimize the risk of bile duct injury. We recommend that this Safe Chole program is really adopted internationally, and I would encourage you to take this program back to your home institution. I personally am instituting this for our residents, and all of them are required to take this course now in their second year. So I would encourage this to really be adopted and spread. So I hope to charge all of you in the audience with being evangelists for this and taking this out there. The 6-step program, as has been discussed, to understand the critical view of safety, to understand aberrant anatomy, to use cholangiography, or if you prefer, ICG or ultrasound, the intraoperative timeout before clipping and cutting, again, to minimize those perceptual errors, to recognize the difficult cholecystectomy and how to manage them, and then to call for help early. It's never a sign of weakness to call for help. It's actually a sign of strength to call for help. All of this is available for free online, and this has really been a major initiative of SAGES, so please go on to the SAGES website. So this is just stepping through those 6 steps: the critical view of safety, the understanding of the aberrant anatomy, cholangiography, the timeout. The timeout, by the way, I now routinely take this photo of the doublet view of the critical view of safety, and I put it in my patient record. There's great evidence that a lot of surgeons who say they get the critical view of safety don't actually get it, so I like to have photographic documentation in my chart. To understand what to do in the difficult cholecystectomy, and then again, call for help when you need it. And that's it. Thank you very much.